Hi, good morning, good afternoon, and good evening to everyone. This is our monthly INL DDR partners meeting that we have on a monthly basis. We have partners from all over the world, experts, our international organization partners in other countries. And today we are going to have two presentations and also have time for discussion. One is quality improvement for substance use disorders treatment systems with Victor Kaposha, who's a consultant, and also one from INL, I guess, branch chief for counter narcotics on quality improvement and next steps for that to share with everyone. I will go ahead and introduce Victor Kaposho and ask him to give some examples of quality assurance. This is one thing that our office is working towards to create not only professionals in the field working on substance use disorders, but also the quality and the treatment of the centers and the systems for those with substance use disorders. So Victor, I'm going to go ahead and ask you to share your slides and to give us some good tools and maybe some examples of quality assurance that are applicable in the way that, through your 20 years plus of experience have found to be helpful. So really, thank you so much for sharing these insights with us this morning.
More experience than I know what to do with sometimes. But anyway, it's great to see friends from different parts of the world and locally. So good morning, afternoon, and evening, as Charlotte said. I want to really thank you for this opportunity to share with you because I've learned a lot from listening to, participating in these partner calls over the course of this last year. And I look forward to our conversation today and hope we can make it as much of a conversation as possible. And that I continue to learn from you all, and hopefully this stimulates some ideas and thoughts for you as well. Now, what's not happening is, I go down. That's why it's not happening. So as a result of our discussion today, which should take 12 minutes or so, hopefully, these are things that I hope will stimulate for you. First and foremost is really to understand, and I'm going to use the word patient, but it really is in the literature and the literature of quality improvement spoken of as customer. Our patients are in effect customers. The first point is that we understand what their experience is, what the customer experience within our system is, what the needs are, obviously, and what their experience encountering the systems that we are responsible for. And if you're a government, you're responsible for regulatory and financing and et cetera systems and technical systems. And if you're a provider organization, you are responsible for systems that actually deliver interventions to people who come to your door in one form or another. In some respects, this may not be as obvious as it sounds to our field. And we pride ourselves, rightfully so, on using our lived experience and bringing our lived experience to the work that we do. Unfortunately, there's a potential for presumption in that our lived experience tells us something about the people that we are serving, and we should be careful not to make that error, and that we know that our lived experience is our lived experience and not necessarily what another person is experiencing within our systems. The second that I hope we will come to discuss and talk about is the fact that there is a basic approach. There are basic approaches to quality improvement in the system that you work with. They're proven, they're practical, they're workable. This is the Toyota system, the Plan, Do, Study, Act system, which we'll focus on. These are all related. Edward Deming is discussed and referenced as sort of the father of this movement back at the turn of the last century. Third, we understand and employ base standards and measures that define the quality of treatment for substance use disorders. Something like a specific standard would be to understand, to have the ratio between opiate use, number of opiate use diagnosis in a particular system, and the number of prescriptions that are with appropriate medication for those diagnoses. And clearly you want a close ratio to it. And then finally, in our discussion, that we learn from each other's experience. And the second part of this is really important. That the fact that we're improving doesn't mean failure. This is oftentimes within the systems that we work, there is the feeling that an error or not achieving an outcome is a result of someone's personal failure, is generally a result of the way in which the system is designed. And in fact, when flaws are surfaced, we don't want to punish. What we want to do is recognize, reward, and solve. So I thought I'd spend just a minute on what sort of led me to focus on quality. And hopefully maybe this will have you begin to think about the circumstances that lead you down this path, or have led you down this path. So there was a period of time in the past that I was administratively responsible for the health department in the city of Boston. During that period of time, HIV was being transmitted primarily through needle sharing. So what would you do under those circumstances? I assume you do sort of what we did, which was to take a look across the city at what was available in terms of treatment for people at that point, opiate use disorders, sharing needles. And what did we find? It was not encouraging, I will tell you that. I think that this is an experience that many of you can relate to in terms of the transmission of HIV as a result of needle sharing, and the importance of focusing on the treatment system. What we found was long waiting lists. We found off-putting enrollment systems. We found incredibly high dropout rates. We found people being thrown out of programs for various non-compliant reasons. In short, we found a system full of barriers. And why? I mean, you know, the people working in these programs are sainted, right? I mean, they're not dumb people. They are professionals. They're knowledgeable. But those were the results. Why? The answer is essentially in a phrase that's become popular in the healthcare quality improvement field. Every system is perfectly designed to get the results that it gets. So in effect, what we had at in the city of Boston at that point in time was a system designed unintentionally, but as it evolved over the years, that created barriers to treatment. And so that's the basis that you begin to say, we can do better. We can find ways to improve that. And in effect, over a period of time there was a collective of work groups that came together that ended up being able to deliver a mobile van, one of the earliest this was in the mid-late 1980s. as well as reducing the barriers that had to do with when you call, you can only call between the hours of 7 a.m. and 9, and if you don't call, then we don't take your call later, and those kinds of things. So, is your system meeting the patient customer needs? What do you want to look at? You want to look at data sources, right? What information are you looking at? Particularly, are you looking at wait list length? Are you looking at the time it takes from the period where the patient makes contact to actually being able to see someone? Are you looking at retention? Are you looking at dropout rates? Are you looking at overall engagement? Are you looking at medication use? Are you looking at warm handoffs? These are some examples of data sources that you might want to begin to focus at. And behind those kinds of questions is, where is that data collected? Where is it stored? Who has access to it? And a variety of questions of that nature. Ask the customer, especially the one who didn't stay. You probably learn more from that customer than you will from the customer that went through and fills out a checklist that says 4 stars, 4 stars, 4 stars for this, that, and the meals were pretty good. And so that means focus groups, that means outreach, that means follow-up with and outreach to people. It is not necessarily an easy task, but it's a good resource. This last one I put a lot of emphasis on. I refer you to the reference that is on the slide. I assume these slides will be available to you. The major quality improvement process experience that was done in the US in relatively recent time for the substance use disorder field was the NIATEX program. The Network for the Improvement of Addiction Treatment is what NIATEX stood for. Was based out of the University of Wisconsin. It was funded initially by the Robert Wood Johnson Foundation and then partnered with SAMHSA. There were over 1,000 systems, programs in the U.S. that became a part of this improvement process. How did the improvement process begin? What was asked of every CEO of those more than 1,000 programs was that they put themselves in the role of a patient. They start without assuming they know their number. They look up their number on public sources for their organization. They call those numbers, and by the way, a lot of those calls found that the numbers were wrong, or old numbers, or numbers that, as they changed their phone systems, went into endless loops of rings. So you put yourself in a customer role and experience. Dave Gustafson, who did the program leadership of this at the University of Wisconsin, actually had himself admitted into a program and in Wisconsin, went through the whole process. Dave was one of the early founders of the Institute of Healthcare Improvement, which focused on medical errors internationally. When he was doing that role, he had himself admitted as a heart patient, literally going all the way through, not just the admission desk, but lying on a gurney, waiting to be examined for this, that, or the other. And you begin to understand what your system is actually doing and delivering. So that walkthrough experience is a terrific way in which you begin to understand what the customer is experiencing. So when we're talking about doing this presentation, Anne suggested that I come up with 5 steps that I could share with you to really do. And so I that on the slide, but really here are 7. And first, we've talked about it is that you understand what the experience of your patient is in your system. Second, you want a clear, specific target to improve, a measurable goal, wait time retention. Now, I want to improve wait time. I want to reduce my wait list. That's not a goal. That's not a target. More or improve is not a measure. It's not a number. I want to have people admitted within 2 days of contact. I want to reduce my wait list to, 5 people on a rotating basis. Those are targets that are specific. You want to identify a change leader, a champion. I think in today's parlance of social media and all, we'd call this a major influencer in your system. Someone who has clear support from the leadership of the organization, of the system. You want to look outside your organization to learn how others have addressed this goal. There was a period of time where I was responsible for running a multi-approach treatment program that had just multiple levels of care. We had detoxification programs, outpatient, residential, medication, prevention, the whole range. But we had a problem getting people into our particularly detoxification beds. And the problem was the way in which we had our system designed. There was no question about it. There was huge demand. The phone rang. There were wait lists, supposedly, but there were empty beds. If I walked into that place, which I would, by the way, from time to time, call the number, just say, I'd say who I was. I think it's important to be forthcoming, but you just ask, what are the beds available? Or I'd walk in, you walk around, and you see and you observe. But what we did is put together a work group to address the issue so that we had close to 98% revolving occupancy all the time in our detox. So that when a person called anytime, if there was a bed, it wasn't just from 7 to 9 in the morning, it was any time that you would be admitted. And who did we use? Where did we get our processes? We went to the Marriott Hotel. Marriott Hotel is very experienced in putting people in beds, right? And it's in their interest to do that, just as it was in the patient's interest for us to do that. And we had the Marriott Hotel volunteered a human resource person to come and work with us for a 6-month period of time. So go outside your organization. There are other systems that have addressed the issues that you are facing. And the last 3 are the rapid cycle. Make a change. Don't wait to plan. Don't develop huge schemes. Try something. Just do something. But when you do it, measure it, evaluate it. What change did it make in wait lists? What change did it make in the rate of medication prescriptions relative to opioid use disorders? What change did it make in the length of time that a person was engaged in your organization? So you evaluate, then do it again, because you are continuing to try and work. First, here we have and not 5, but 7 things that one can do. This is what we focused on, the PDSA system. This is find your target. What are you going to do? Do it. Look at the results and what happened. Make your adjustments in response to the result. Repeat the cycle until the system is producing what you desire. There's a lot of literature on this. The NIATEC's website is full of specific steps. So here are a few questions for you to think about. How do you know about your patient's experience with your system, your service? What data or other indicators have you used to track the quality of your service? These are some things we might want to discuss either now if we have time, or you want to think about, or we want to communicate about. What approaches have you used to systematically improve service quality? What obstacles have you encountered in trying to improve quality? You will encounter obstacles. There's sometimes resistance to change. There are sometimes resource questions. There are sometimes changing personnel practices and policies. There are some very select resources. I've referenced the NIATEX website. I encourage you to look at it. The UN and WHO standards that have just been issued is a terrific document. I'm sure you'll hear more about it, and you've heard, I know there's been some presentations about this in earlier discussions. The addiction treatment quality, next one from RTI, was put together initially for Shatterproof, which is a consumer-driven substance use disorder stakeholder group in the US that is focused on, or focusing among other things, on improving access, but also improving quality. And if you were looking for specific clinical measures to track, I encourage you to look at this resource, the American Society of Addiction Medicine, because the measures that they have come up with that have to do with medication ratios, that have to do with engagement ratios, those indicators have been tested and validated, and so they are useful in that respect. That's it. I would hopefully this leads and fits with what Brian is trying to talk about. The one other item I will just conclude with as we is in when you undertake quality improvement programs. The NIATEX experience that I referenced, where over 1,000 organizations were involved, that was pretty rigidly evaluated. The findings were that programs that undertook quality improvement on a serious basis improved their organizational culture, improved staff satisfaction, improved the retention of patients, and actually improved their financial position because they were able to operate more efficiently. So there's this research to support their to support the benefits of getting involved in this way. I like this little expression: if you can't measure it, you can't improve it. Thanks very much. I'm happy to discuss any questions or anything else. So
Victor, that was fantastic. You've got lots of clapping and handshakes for that. Really, you know, quality assurance is a huge thing to talk about systems and to services, and to really cover it in a short amount of time to give us some, you know, quick tips on how you can do some of these things. And then, of course, all the excellent resources. I saw in the chat that Lori Crom was also talking about NIAX, and that's really, you know, a great resource. So lots of people know that and use that. So thank you for that. I'm going to open it up to the floor. We do have a couple of minutes, and then I'll let Brian do his presentation. But any just initial thoughts or questions that you have? I see Becky saying that they partnered with them for a while. She had experience with NIAX. But any questions for Victor Capaccio?
Becky was a good partner for, indeed.
I can't see the hands as well. I don't know, maybe Carrie, if you see them before me. Always just call out.
There's one here. Yeah.
Yeah, it's me. Giovanna.
I just thought I would break the ice. I actually don't have a question. I just want to take Victor's presentation, of which I've taken all of the screenshots and follow all of the links. Of course, we know Niatex, but I found for me, everything was incredibly useful. But two things I will highlight just because they are close to my heart. One of the things why reasons why we did the standards and we started working on quality was the human rights abuses that are perpetrated in the name of treatment in many countries. And I really like what Victor also said, and I will start using it. Another very good reason is that when we look at the system, we find a system that is full of barriers and that is not there to allow people who need to access the services, or it's at least it seems like that, even if people are very well intentioned. So I think that that is certainly something that I will start bringing to the attention of everybody even more. And then of course, I think I've mentioned a couple of times that as we start implementing this more widely, I would want to start thinking about a way of evaluating what we do beyond, of course, what we are doing anyway, which is monitoring and collecting a lot of data as we go, and really and I think that some of the resources that Victor has shared will be of great help. And we were anyway thinking about to see how to integrate Niatex in our work in different ways. I'm thinking a lot of work that we would like to do on stigma would benefit from this kind of model as well. So in reality, as I said, I don't have comments, just thanking you for giving us loads of ideas that we can work on.
Niatex grew out of the work that when I described the Marriott Hotel experience, we did that in a treatment program in the North Shore of Massachusetts, and we called it the Darwin Project. And we actually had work group around beds, we had a work group around purchasing, we had a work group around reimbursement, etc. The basis of that became the basis of Niatex, and the opportunity at the time that I spent at the Robert Wood Johnson Foundation provided that essential design. And initially, and I was familiar, we were familiar at that point with the Institute of Healthcare Improvement and the work that they have done, as I said, internationally. Many of you may have experienced them in different countries around reducing medical errors. And so I wanted them to get involved in the addiction world and the substance use disorder world. And at that time, they said, nah, we have too many other things to do. But what Don Berg did, he did refer me to two other people, Paul Batalden, who is credited in some respects with the expression that every system is perfectly designed to get the results that it gets, which is obvious, but it's significant. And then Dave Gustafson at the University of Wisconsin. And it was the three of them that really took the Deming work and transferred it to the healthcare field. And it's, Niatex was a driver of taking what was done in the healthcare world and saying it needs to be done in the behavioral health world as well. So there's a nice continuity there of it would be great for the UNODC, WHO, INL to hold together and for broader spread. The work that Annette is doing, is consistent with this. And implementing those standards.
Yes, fantastic. I'm looking through the chats. I'll just kind of mention that Lori said there might be some online courses. Thank you, UNODC, Giovanna, for mentioning, all really the benefits of the information that Victor has mentioned. I also saw that Anya was thanking you, Victor, for your early adoption of this. And really sharing all of your lessons learned. I do want to make sure that we have enough time for Brian to present. So I will let everybody continue to chat with each other. I want to thank Victor again for the really very useful and concise presentation, very helpful. I know that Brian, we all know that Brian, I don't know if you're going to stick to your 15 minutes, but I know we all want discussion. So while this is a 1 hour call, if we run over, I welcome everybody to just stay on, but I think that we are going to try to keep to our hour limit today. But I just wanted to let everybody know that, as you can stay, that would be great. And so now let me introduce Brian, who's the U.S. Department of State, International Narcotics and Law Enforcement Affairs Counter Narcotics Branch Chief. So Brian, we'll let you share your slides.
Thank you so much, Charlotte, and thank you, Victor, for the wonderful presentation. Yes, it's really nice to have an hour to have the theme of quality come up. And I always say that last decade was one of workforce development and training, and this is the decade of quality, where we need to put an extra emphasis on this above everything else, because we have a system, a way to now really address this, and the network and the infrastructure to do so. Let me see if I can share my screen. Will that do it? Screen, let me see, share. You all see this slide?
Yep,
Yes.
we see that. Looks great.
So yes, it's a home improvement slide that I put up to sort of emphasize that we are here building this architecture. And you all know the alphabet soup that we've all been a part of over the years of building together: ISUP, ICUDDR, ITTC, and GCCC, and so forth and so on. Today, I'm going to be highlighting a new acronym. Of course, there's ICQ, which we'll discuss briefly, but I also want to introduce PIQAT for those that haven't heard of it in the past few days. And so I'll discuss that. I will say that my slides are not original. I have basically formatted slides from Annette Dale Pereira's presentations and Rodrigo Portilla's presentations and others. So I have a few originals, but not too many. And I also dug deep into the DDR photo album to pull together some pictures to help illustrate some of the content that I have today. So thanks for those that have contributed photos. So Kim Johnson has always said, what is the problem we're trying to solve? And that resonates with me. So what is the problem that we are trying to solve? Giovanna alluded to it earlier. The problem that we are trying to solve is that around the world, we see what is described as treatment, which we know is not, and does a great disservice to the field. Poor quality of treatment services. And this photograph to the right is a mock photograph. It's not a real patient. It was provided by Alexandra Hill, a former chief of CCAT, to illustrate the type of practices that we find in Latin America and some places that call themselves treatment centers. These type of practices are outside of the evidence. And as a result of having poor quality in treatment services, we will find that treatment fails. And then you find that policymakers look for extreme drug policies because they lose hope and faith in the science of treatment. You see then resulting crime and transnational organized criminal activity that continues and is sort of fueled by the lack of treatment and quality. And you see that there is a questioning of research and science. Does this actually work? Does treatment work? Look, it didn't work here. And we need to be very clear that this is not treatment. Many of us around the virtual room here have been to many treatment programs around the world and done many missions to many countries. And when we come across these scenarios, it can be very disheartening, but it's more disheartening to hear people referring to it as treatment, and I think it gives the field a really bad name. So there's been efforts that have taken place over the years on a regional basis, on a global basis. CCAT and COPOLAD have worked with a program of quality assurance in Latin America and the Caribbean with the support of the European Union. The EU has had minimum quality standards in drug demand reduction and then DDR in the European Union. The AU has had African continental minimum quality standards for drug treatment, and UNODC and WHO at a global level have developed the QA toolkits for services and systems to over 20 countries. What has been very exciting has been the harmonization of these efforts and building a new global architecture to address quality. And kudos go really to UNODC and WHO for bringing this, I'd say the implementer community together, the scientific community together, but also most importantly, the member states to recognize and to elevate this into the discussions in political fora. And so the International Standards for the Treatment of Drug Use Disorders is the groundbreaking document that we can now reference and refer to as the sort of first exercise to, at this level of comprehensiveness, pull together what are those international standards that we should all be focused on. And based on that, a synthesis of harmonizing all of these other regional events that I showed on the last page, how do we come together to identify what those key quality standards are? Those international standards led to the next exercise to develop key quality standards, which were finalized last year. And here are the key quality standards as agreed to by many of the international organizations. And you can see that there are 4 categories here along which these standards are elaborated. Effective management of the services, individualized patient-centered treatment and care, timely access to evidence-based interventions, and promotion of patient rights, patient health, safety, and human rights. Okay. Many of you know that ICQ, the International Consortium for Quality in Drug Use Disorder Treatment, was launched at the meeting of the International Society for Substance Use Professionals this year in May. And there are 3 pillars or 3 components to ICQ. First are the quality assurance agencies themselves. So trying to bring together those agencies around the world that promote and are responsible for ensuring quality in the treatment system. Second are the actual services for substance use treatment, those that are providing services inpatient, outpatient, hospital, community-based settings, and so forth. And the third are the patient, family advocacy organizations, so that in having these 3 networks connect under one umbrella, you have a full dialogue of the system, those that monitor and regulate, those that provide the services, those that receive the services, and are supporters of those that receive the services. So it is, I think, a perfect check and balance in the system to have the most productive conversation in improving quality at that level. But I want to highlight ICQ in this presentation so that you also understand what PIQAT is in relation to ICQ. And that's why I'm covering ground that many of you already know. I want to say that one thing that is very exciting for me is that within ICQ, there is a high-level network or a high-level group that is comprised of 5 quality assurance agencies, comprising of the countries of Chile, Pakistan, United Kingdom, and there are 2 quality assurance agencies from the US, one that accredits in the US, and one that works in the US and internationally as well. This is very exciting, but we did do a lot of outreach. And when I say we, I mean the international partners that have been supporting ICQ team. It was very concerning at the same time that the team felt that to sort of meet this high-level group, there were certain criteria that was necessary to meet, and yet only these 5 agencies sort of qualified at that level with alignment of the international standards and meeting all of that criteria. So we are hoping that that group can grow and expand, and I'll describe a little bit in a few minutes how that could happen. But one thing that is very exciting with this group that currently contains just 5 quality assurance agencies is that they're working together to develop an international seal based on the international key quality standards. Just like you may have an ISO seal, or ASAM or other seals that are out there, to have an international key quality standard seal is very important. We're not taking away the sovereignty or the national sort of domain of a country to accredit their services. On the contrary, we're saying you meet your national standards as you normally would, but you also now meet the international standard as well. And so this architecture of key quality standards is really valuable in helping build a common framework for how we objectively identify what centers are meeting that standard and what centers are we should not call centers for substance use treatment because they are completely off the mark, or those that are working in progress to get there. Well, before I leave, I want to say one more thing about ICQ. ICQ has been established and founded as a subunit of the Colombo Plan. So within the Drug Advisory Program, we have GCCC, and ICQ similarly is comprised of agencies that in most cases include government entities. So it's within an international organization framework, but it is a subunit that is distinct in its mission and scope. Okay, I want to emphasize that there are different stages in a country's development for quality assurance. And this is important to recognize. If we were getting really into the weeds, we could start thinking of countries that fit into different categories. And this is helpful because you want to help countries diagnose where they are and what's the developmental step is, the next step to sort of get to the next level. So at the lowest rung, you have no guidance, no standards, no quality assurance system or mechanism. Then you have national or regional government guidelines that exist, but there's really no monitoring or implementation of that system. On that, you have, yes, the country may have generic standards, but you don't really have any monitoring or implementation in that setting. And at the next level, okay, so you have specialized drug use disorder treatment standards, but again, you still don't have any monitoring or implementation. Next level of development, okay, now we have quality assurance mechanisms, and there is some monitoring and there is some accreditation, but it's not required by the government. It's optional. Next level, now there's licensing and registration requirements. Providers need to show that they meet the minimum requirements in order to be able to provide services or be eligible for some type of funding from the government. At the next level, you have now the treatment services that are now covered by regional or national health or social care quality assurance mechanisms. And now it's much more integrated. And at the very final step, you now have requirement. You have national or regional government quality assurance systems that are aligned with the international guidance in relation to the international standards, the quality assurance methodology, and the quality improvement mechanism. Those 5 organizations or countries that I mentioned earlier, those 5 QA agencies meet this 8th step. And I think our goal is to support and provide assistance to help other countries get to that category number 8, which I think would be the ideal for countries to reach. So now I'm going to introduce to you a program that we are initiating to help us reach that. I am terming the pronunciation PIQAT, P-I-Q-A-T, which stands for the Program for International Quality Assurance in Treatment, PIQAT. And I will say that PIQAT is a project. It is an INL-funded project. ICQ is an organization. It's a component of the Drug Advisory Program of the Colombo Plan. But PIQAT is a project. It's a project that INL is funding through 3 international organizations this year: the Colombo Plan, OAS, CCAD, and UNODC. And the idea is that we are proposing to work collaboratively in a harmonized way between the 3 international organizations in 28 countries over the next 2 years. And I didn't put the names of the countries because, of course, we need to check with them, make sure that they are on board. This is our initial thought and reaction. So that number may go up or down, but that is our wish list for the coming couple of years. The idea is that international organizations would take the lead. A particular one would take a lead in a particular country, with the support of other partners, IOs and other stakeholders, to help implement or to strengthen existing quality assurance programs that are already under development in these countries so that they progress from those steps 1 through 8 that I mentioned previously. To conduct this global quality assurance mechanism within PIQAT of strengthening that quality, it's important to develop an expert network that will help and be there to guide the process. So we've discussed that PIQAT would first need to develop a competency framework. If you want to be part of the quality assurance expert network, what would that require? What competencies would be required to participate in that? And what we're hoping is that we will be launching an open recruitment process in the coming months, which will have a screening of candidates who would like to be who would like to take on this role as experts in quality assurance, and they would be providing consistent support to the national agencies that are developing their quality assurance system through each step of the process. So I would imagine that they would be assigned specific countries, and over many years, they would be the interlocutors to support the very intensive work that the international organizations will be funding in these 28 countries and helping take them through the QA, through the PIQAT process that I'm about to describe. So what is this process? There are 13 steps, auspicious 13, to implement the PIQAT program. And I'm going to just briefly give you the whirlwind of what that is. First, we need to make sure that the country is interested and get their support. We would need a letter of interest from them. We would need to then create a country team to then begin the project. Then we would need to do an assessment of the system of that country for quality assurance. Following that, a plan of action would be developed for the system and then for the services. Then there would be a training for quality assurance inspectors, those people that are going to go out there to the field. Then there would be a monitoring cycle. Number one, we would find issues in that, and so there would need to be some revision and adjustment for some of those facilities that didn't meet the mark the first time around. And there would be an evaluation of cycles 1 and 2. Next, there would be a 3rd and 4th cycle of monitoring. And beyond that, there would be a second evaluation, which would be concluded by a process of sustainability, where we would conclude our international work and the country would continue to implement that process on their own. This is the big picture for the PIQAT implementation steps that we are looking at implementing in the countries that join the project. And the quality assurance expert that I described in the previous slide would be involved in all of these steps, from step 3 all the way through to step 12 and 13. So let me break down these steps one by one, mindful that we've only got 10 minutes left. Okay, first we want to enlist the country in developing a QA process. We would be offering training sessions on the international standards for the treatment of substance use disorders. We'd present the key quality universal standards, and we'd provide leave-behind materials and next steps for program participation. Second, we would secure the country's commitment. We would want them to sign some type of letter of intent or an MOU with the interested country. And that should contain several things that we would want the country to commit to. Minimum requirements might include, give us your national point of contact, your commitment to participate in these 13 steps, your commitment to share data, to cooperate with international partners, to make public some of this data and the reports, to work towards sustainability. We'd also want them to consider language to facilitate access in working with regional or subnational governments as well. It should not just be at the national level. We would want to create or identify a quality assurance country team that would be composed of key stakeholders, including government representatives and international organization representatives. There would be a launch event for the program. And we would develop a directory of participants and roles and produce a document that would define the structure, aims, and function of the country team. So this is the country team formation process. The fourth process is a systems analysis, applying the systems level tool, which has already existed, has been created to diagnose the national and subnational treatment system. The global quality assurance experts would conduct visits to the countries. They would look at the national level, at the subnational level, and they would produce a report with maps that would indicate the strength and challenges of service provision and systems level improvement plan. There would be a mapping of all of the services in the country, and a directory would be published of all of these services as well. At this point, I want to highlight that this is what a healthy system would look like. You have fewer long-term residential stay services, then you have a little bit more when you get to specialized services with lower intensity, like outpatient, then more for primary healthcare services, all the way down to mutual care, self-care at the bottom of that pyramid. And I want to show some examples that we've already seen. This one from KPK in Pakistan, where you can actually show a misaligned system where you have, and the color shows the quality of that system. So short-term inpatient you have sufficient of, and you also have green, that means good quality, but long-term residential you have fewer of, and yellow. But look at the bottom of that pyramid. It's a rocket ship. It's not a pyramid. And so not only do you have few outpatient and recovery management, but you also have them at a poor quality level. And then you have all the processes to feed into treatment, the outreach, screening, brief intervention, and referral to treatment services, and health and social care. And you can see that some of these are also lacking. That's for KPK. This is for Punjab. You could do this on a province by province basis and come up with a very clear diagnostic tool for where you can start shaping the system with recommendations. Fifth would be developing action plans at the systems level. So that would be adapting the infrastructure to the country, designing and adopting action plans to guide the implementation. So
There are some problems with the...
And we can't hear you anymore. We can see your slide.
the sixth step is developing an...
Oh, Brian, we lost you for a minute. Now we can hear you again.
Sorry.
Do you want to summarize your last slide real quick?
The last summary was that we should be working at the service level, and there are many things that can be included into an action plan, including workforce development and credentialing, tying it into our existing work. The sixth is to develop an action plan at the service level and workforce improvement level. And so now we're getting into adapting the standards to develop these types of criteria that we would be evaluating. And then you can see the color scheme that would identify the quality of that. So developing a national assessment form and then working to present these tools to the national stakeholders, including the treatment services. Next, we want to, this is still the same step. We want to identify a national quality assurance agency that will conduct the monitoring, develop a group of national inspectors or agents that would be traveling throughout the country, and supporting a sustainability plan for high-level officials to identify a monitoring and follow-up cycle, and to pursue policy changes or legislation that may be necessary to ensure long-term compliance by treatment programs with national regulation. Seventh would be the training for inspectors. International organizations with the support of global QA experts would train and prepare for field deployment. And then eighth, we would start our first cycle. And so the global QA expert travels with the national agent or inspectors to assess all the facilities in the country and issue accreditation where appropriate. And then they would be accredited for X number of years. And if they don't meet that, they would have to develop quality improvement plans, which would be submitted over to the agency. Those would be collected and reviewed by the agency, and there would be continued support to strengthen those services. The next step would be the second cycle, which would be once receiving the quality improvement plan, the remaining non-accredited facilities are visited for follow-up with national QA agents and global experts. If compliant, they're issued an accreditation, and this would be phased in over several years. And then there would be an evaluation of the full system, and we would see there would be a public report that identified strengths and weaknesses. There would be a meeting of stakeholders, public and private sectors, and patient advocacy groups to present the results of the report, and there would be some public release. And at this stage, the National QA Agency would then qualify to join that ICQ Advanced Network, that's step number 8 that I previously shared within ICQ. So ICQ would receive these countries as members at this state. All of these steps, 8 and 9, would be repeated in a 3rd and 4th cycle of monitoring, but this time there would be less funding and support from the international partners as we seek sustainability. And finally, there would be a 12th step of evaluation where another public report would be issued, our 2nd evaluation report, and once again, a national meeting of stakeholders to share the results, and the QA agency would continue to participate in meetings. And finally, there's sustainability. The government alone would fund quality assurance. Quality assurance agencies would continue to participate in ICQ meetings and events, and they could join optionally a peer review process to share good practices or conduct further research. This is the ideal, folks. This is the ideal quality assurance mechanism. Of course, it will vary country to country, but this is what we're hoping we can work toward as a collection of partners on the issue of quality assurance. So with that and 2 minutes remaining, thank you all. I know I really ran through those slides quickly, but I'm glad it was recorded because we can share the slides and you can always freeze frame if you want to read that in more detail. So that's PIQAT and its relationship to ICQ and the work that INL is hoping to support in the coming years. Thank you.
Thank you, Brian. You stuck to time. I'm going to just kind of summarize some of the chat that was going on. There was a discussion, are we using a different acronym other than SUD because that's in the DSM-5? No, there's no terminology change. I'll just say that. Also, there's a back and forth conversation between GCCC that is trying to really have the workforce credentialed and asking if that should be part of this. And that was replying, yes, that should be part of the plan, that we should require, a certification of the workforce as well. But we should definitely talk more about that. And then Lori from the ITTC said that we should include the ITTCs and part of that working group, stakeholders group, and I would agree. And so we definitely like to have lots of collaboration. That's one of the reasons that we do this call. Any other questions for Brian? We have 1 minute. Shout out. Comments.
He used in the scale, he used the term DUD. So I was just confused about what that was being used.
Drug use disorders. I can't remember if the international standards, I think it was for drug use disorders, I think is what the international standards use. So I was probably just using that terminology.
We're not switching to that term. We're still using.
I'm still using substance use because, yes, for alcohol and other issues. Yeah.
So that alcohol is included.
And I think I can safely say that everybody wants a copy of your slides, Brian. So we will share those out to all the partners that were on today's call. I am going to try to stick to our time. Please feel free to send additional questions our way. We're really excited about this new project that INL will be supporting through international partners. Our next call and our last call really for the whole year is December 14th. A reminder that your calendar invite holds your calendar, but the agenda and the link are provided the day before in an email from Ann Schick, who's on our team. Next month, we're going to have the International Consortium for Universities for Drug Demand Reduction, ICU, DDR, Carrie Hopkin Isles, and of course the host for our partner calls. So thank you very much, ICU DDR, for hosting all of our calls on the new resources that they have on their website and some of the other activities that they're doing. I also want to welcome the International Nurses Society on Addictions to their first attendance of our partner calls. We just now added them, and they have kindly agreed to present on the work that they do and their contributions to help developing a new nursing credential with GCCC. And so that will also be presented at our next call in December. We don't have any other scheduled topics for next year. So if you have ideas for presenting, please share those with me and with Ann Schick and our team. And we look forward to sharing more of what we are doing and how we can collaborate and really support those with substance use disorders in the field. So I thank everybody, and I hope everybody has a wonderful rest of their days and evenings.
Bye.
Bye, everyone. Thank you.
Bye.
Thank you.
Bye. Bye.